3, 2, 1. We are live now.
Great. Hello, everyone. Dr. Ankita Ahuja this side. And as we have been going through this shoulder series, today I will be trying to cover some of the miscellaneous topics which might have been covered in bits and pieces here and there. But let's see and go ahead and see. And if at the end there are any other topic remaining which you are interested in, you can just post that on the chat group and we'll try to cover it in the next session, which will be a case-based session. So let's start with labrum and labral tear. I know it would have been dealt with instability and slap tear as well, but let me just briefly take you through an approach to the labrum. So first of all, as you all are aware, that labrum is something which is all outlining the glenoid and it creates the cavity deeper so that your humeral head can sit well in there. So this green thing represents your labrum. Your labrum at the molecular level is formed of collagen fibers, which can be circumferential fibers and radial fibers, similar to your menisci in the knee. Why I'm telling you this? This is just to tell you that these fibers, as you can see in the image, although not that greatly created image, but these fibers are really well arranged. What is the importance of these being well arranged? If anything is well arranged on an MRI, it should look homogeneous. So these are well arranged collagen fibers, so it should look homogeneously dark. So it should look all the time dark. If there is any bright signal within, that is something which we are concerned about. So always remember, similar to menisci, it should look completely dark. Then how do you approach an labrum on MRI? So just imagine we are seeing the labrum end face. The labrum is divided into these 6 quadrants: superior, posterior, superior, anterior, superior. Similarly, anterior, inferior, and posterior, inferior. And the inferior-most quadrant is the inferior quadrant. So overall, there are 6 quadrants, just representing those same quadrants on a sagittal MRI. So this is a sagittal MRI. This is coracoid process. So you know that this is anterior. So this would be your anterior superior and anterior inferior. And this would be your posterior superior and posterior inferior. So whenever you're looking at the MRI, to figure out which quadrant you are really in, you need to go back on your sagittal and see which quadrant you are corresponding to, right? Some people even use o'clock positions for it. So ideally, preferably 3 o'clock should be labeled as anterior. But just to avoid that confusion, in the present day and age, the terms used are anterior and posterior itself, not the o'clock position. And if you want to use both, you use both, but preferably mention anterior or posterior so that there is no confusion at all, right? So whenever you, being orthopedicians, are reading our reports, sometimes there is a confusion. Some people call anterior 3, some people call posterior 3. Ideally, anterior should be 3, but always read the term along with it anterior as well. So it should be specifying something as anterior. So now, how do you approach the labrum? So your labrum is circumferential, like we saw. The superior labrum is best seen on these coronal images. So this is your coronal plane and this is your axial plane. So superior labrum, this triangle over here, is best seen on your coronal weighted images. And similarly, your inferior labrum triangle is again better appreciated on your coronal weighted images. This, and on your axial weighted images, you see anterior and posterior labrum. To be sure whether you are in the anterior superior area or anterior inferior area, you need to correlate with your sagittal weighted images. It might be sometimes a little difficult on films if you're reading per se, because you cannot correlate, but still you get a rough idea. So how do personally I go and approach a labrum? So I start seeing the superior labrum. I see that same bit where it would be corresponding on the axial weighted images. So this would be the area of superior labrum. Then from there on, I start tracing the labrum on the axial weighted images. So here is this anterior triangle is your anterior labrum, coming down till the inferior most labrum. And similarly, this posterior triangle is your posterior labrum, which is pretty diminutive in this case in the posterior superior quadrant. So this is how you should see the labrum on your axial weighted images, but that doesn't mean you need to see it only on axial. It's best seen on axial, especially the anterior and posterior labrum, but you need to go back and forth and see it on coronal and your sagittally weighted images as well. We preferably use this sequence, which is PD sequence. So how do you differentiate this sequence from this? If you look at it, there is subcutaneous fat, which is bright. Whenever the subcutaneous fat is bright, it would be a PD weighted image. And when the subcutaneous fat is dark, it is your fat is suppressed. So it looks dark. So this would be a PD fat suppressed image. And similarly, if you look at the bones, in this bones are dark. So this is your PD fat suppressed image. In this bones are bright. Bright thing is usually fat. One of the reasons is fat. So this is your PD weighted image and this is your PD fat suppressed image. So similarly, this would be almost superior labrum, which would be better seen on coronal weighted images. From here, I move down and trace my anterior superior labrum, posterior superior labrum, and similarly, you keep on tracing that triangle down till you reach the inferior labrum. So this is a simple approach how you see the labrum. Now, what you need to be aware of that there are certain variants within the labrum. So there are three common variants, which are sublabral foramen, sublabral recess, and Buford complex. So let me show you how do they look like. So whenever you're looking at a labrum, you have to keep this in mind. What importantly you would have noted on this image is that this is your anterior superior quadrant, 1 to 3 o'clock, like called. This is your superior labrum, superior quadrant, and this is your again anterior superior quadrant. So all the variants are common in either superior or anterior superior quadrants. Very, very rarely you would see this variant anywhere else. So these variants are particularly limited to anterior superior labrum. Sometimes if there is confusion and you see altered signal going past these two quadrants, then you know that this is more likely a tear because your variant doesn't extend into the other quadrants. So that is one clue once you reach to the labral tear, which I'll be touching upon in a bit. So just to sum up again, these are the three variants, and these are more common in the superior and anterior superior quadrant. So let's start with one, that is first one, sublabral foramen. As we discussed, it is common from 1 o'clock to 3 o'clock position. Now, how would it look like? So let's approach a labrum. I used my coronal weighted images, looked at the superior labrum and looked at the inferior labrum. From here, I'll move on. So I am at the superior labrum section. This green line tells that where I am on the axial. So on the axial, this would be superior labrum, which I'm cutting here on the coronal weighted images. So after this, So this is your superior labrum. Then I move down. So this is your anterior superior labrum. Just try and focus on the anterior quadrant right now. So this triangle over here, which you see is your anterior superior labrum. Then you keep on tracing down. So if you see carefully, here you do not see any fluid deep to this. So this is dark in continuous with the articular cartilage. But once you go down, you see a cleft deep to it, which is still in the anterior superior quadrant. If you see this marker over here. So I again move down, you can still see a very smooth cleft deep to it. Okay, we are still almost at the anterior equator. Then I move down, that cleft is gone. So this cleft is just limited to these two sections over here. It's not over here. It is in this section. It is in this section, and then again it goes off. So this is how your superior sublabral foramen would look like. So it's predominantly in the anterior superior quadrant. It was most likely from 1 to 3 o'clock position, which I'll need to confirm on my sagittal weighted images. And then I'm just tracing down. The labrum again looks fine. So this is how your one of the variants, that is sublabral foramen, would look like and should not be confused with a tear. Now moving on to the next variant, which is your Buford complex. What do you mean by Buford complex? When your anterior superior labrum is absent. So you do not have any anterior superior labrum, and instead you have thickened middle glenohumeral ligament. Now, there are certain situations which we face in day-to-day life that your labrum, anterior superior labrum, is very small and the ligament is thickened. that is called as Buford variant morphology. So that's not the classic Buford morphology, but that's like a Buford variant morphology. So let's see an example again. So again, if you see, this is your coronal and this is your axial. My cursor is passing through here. So that means this section is where the superior labrum is. Better seen on your coronal images. But let's move down over here. In this section, I cannot see any discrete triangle like I can see over here. Okay, then I move down forward. No, before moving down forward, if you have noticed, there is something thickened lying over here, and there is another thickened band over here. So the thickened band, which is most superficial, is your subscapularis tendon. Then if you see any additional band deep to it, that is your middle glenohumeral ligament. And the triangle which you would have seen over here is your anterior superior labrum. So let's move down. So again, you see subscapularis tendon over here. So this is your subscapularis tendon. This is your middle glenohumeral ligament. And maybe you see a tiny kind of a labrum over here, but not very distinctly seen. But as we enter anterior inferior quadrant, can you see such a robust labrum over here? Everybody can identify from far off as well. So this is how your labrum should look like in the anterior superior quadrant for this patient. But instead, you barely see any anterior superior labrum. Instead, you see thickened middle glenohumeral ligament. So this is something which is called as Buford variant morphology because you see a tiny triangle over here. So I would label it as a Buford variant morphology, although it doesn't make much difference. Ideally, the moral of the story is to convey that this is a normal variant and this is not a pathology for which somebody has to hunt and do a surgery for or a labral repair for. So that's why it is important to pick this up. Okay, so even we keep on tracing down and it looked fine. Now coming on to the last variant. So just before moving on to the last variant, just wanted to show you middle glenohumeral ligament again. So if you see this case, in this case, the middle glenohumeral ligament is not that prominent. So in this case, this is your subscapularis tendon and this is your anterior superior labrum, but you do not see any distinct middle glenohumeral ligament. So in all cases, it is not possible to appreciate middle glenohumeral ligament very well unless there is some large effusion and the ligament is a little elevated. So that's fine. But if you see it really prominently, like in this case, it raises a thought of Buford morphology. Now moving on to the sublabral recess, the last variant. It's most common in the superior quadrant, right? And superior quadrant we were seeing on which images? Coronal images. So let's just simply understand the coronal anatomy. So if you see this arrow is pointing down to this gray structure which you see over here. This is your articular cartilage. Then this arrow is pointing down to this triangle which is your superior labrum. And this arrow is pointing down to your biceps tendon which is coming and attaching, which is going across and together this is forming your biceps labral complex which has been covered up for you guys. So this is how your normal biceps labral complex should look like. There can be few variants. So there can be variants like if there is some fluid deep to the labrum, that is between the articular cartilage and the labrum. So this area. So if there is some fluid in this area, then that is called as sublabral recess. And if there is some fluid between the labrum and the biceps tendon, then that is called as something as pseudo slap, right? So let's see example. So your sublabral recess has also been classified into 3 types. Type 1 is when there is no recess. So ideally your biceps labral morphology is classified into 3 types. Type 1 when there is no recess. Type 2 when there is a small recess, and type 3 when there is a large recess. I think there's no significance to know about this, but still it's called as type 1, 2, 3. So this is your basically type 1 in which you do not have recess, and this is how your normal biceps labral morphology complex should look like. Then you have in this case, if you see, you can see your triangle pretty well, and there is a fluid deep to it. So this is your sublabral recess, and in this case you see fluid between the biceps tendon and the labrum as well. So this is your pseudo slap. This should not be called as a slap tear. Again, In this case, you see biceps and labrum are seen well, but you see a large fluid cleft between the articular cartilage and the labrum. So this is a large sublabral recess. So to put all three together, this is your normal morphology. This is small sublabral recess and this is large sublabral recess. So this is how your three variants look like. Now moving on to something which we call as labral tear. When would you call something as labral tear? So these are few points which you need to remember. So till now, we were seeing signal deep to the labrum. But if you see signal within the labrum, then that is something which suggests it's a labral tear. Till now, we were seeing very well-defined margins of the labrum. So if the margins become irregular, then it is something which is labral tear. Then if you see a fluid cleft, which is parallel to the glenoid margin, it's a foramen or a recess. But when the fluid cleft is entering within the labrum or going in another fashion rather than just being parallel to the glenoid margin, then that suggests a labral tear. As I told you before, so if you see something within the superior and anterior superior quadrant, then you think of variance. But that same signal, if it extends across the biceps tendon into the posterior labrum or across the 3 o'clock position, that is across the anterior superior quadrant into the anterior inferior quadrant, then you call that as a tear. So this is a very important point and it helps us take decisions quite often. Then if the space of fluid between the labrum and glenoid is 2 millimeters. So this is just eyeballing. We just don't go by measurements. So it's more of like eyeballing and experience. And lastly, our very friend, that is paralabral cyst, like parameniscal cyst. So if you see this, then you know that you are dealing with something which is labral tear. Now let's see a few examples. So this is just a very classic example in which you see a large paralabral cyst over here, which you can see over here as well. And then you see a fluid cleft over here. And similarly, a fluid cleft over here. And if you see, this is your posterior quadrant labrum triangle. But here you do not appreciate anything distinct. So there is intrasubstance signal within this triangle. And this is a classic labral tear with an associated paralabral cyst. Sometimes if you are in confusion and you see paralabral cyst, then you know definitely you are dealing with something which is a labral tear. Then this is a very beautiful case. So again, we always start with coronal weighted images. This is your biceps tendon. This is your articular cartilage. And this thing is your labrum, right? And you see some signal within the labrum. So this signal is not deep. I'll just go back and forth to show you again. So if you see, this signal is within the labrum. This signal is within the labrum. Something deep would have been here, and that we would have called as sublabral recess. But this is something which is within the labrum. So something within the labrum is a labral tear. So now we go back. We have seen superior labrum. Inferior didn't look that bad, but let's see our anterior and posterior labrum. So this is something which is corresponding to your labrum, superior labrum on axis. So this is your deeper stuff. This is here. And this is your intrasubstance signal, which you see over here. Now you keep on tracing. You have gone down to here. See here. The meniscus triangle is not well appreciated. You see a lot of intrasubstance signal. Similarly, if you see here, you see intrasubstance signal. So I think both anterior superior and posterior superior quadrants are involved, but we go forth and trace it further. So definitely this is altered signal morphology, irregular margins, and I keep on tracing further. It still doesn't look very regular. It looks irregular. And here it starts to look a little regular and triangle shape, right? Again, here it looks a little triangle shape. So almost till here, which would likely be corresponding to my anterior equator. So almost anterior superior quadrant, superior labrum as we see on coronal. And now let's just quickly have a look at the posterior labrum as well. So again, this is the triangle in which there is some intrasubstance signal. Okay, we go forth. Then you see a lot of signal within the labrum again over here. So this entire hypo thing should be your labrum. There is a lot of intrasubstance signal here. Again, there is a fluid cleft which is extending deep. into the posterior inferior quadrant. This might just be a fluid cleft, but there are no variants and it is continuous with the tear which is seen above. So without doubt, this is a tear. This is a labral tear which is extending from superior labrum, going up to the anterior equator and across into the entire posterior labrum. So till here, even you can see the signal till here. So this is something which is an extensive labral tear. Only the inferior and anterior inferior quadrant are spared. So this is how we go about seeing labrum. I have shown you the case and the approach how we see. Now let's see one more interesting case and understand how do we have to see more with labral tears and paralabral cysts. So this is a patient who presented just with shoulder pain, which was a little long standing. So over here you see, this is your coronal PD-weighted images. This is your supraspinatus. And here you see there is some edema in this muscle, which would be infraspinatus. So there is this bright signal within it, which is not seen over here, which would be edema. Then I go on sagittal images and look at the same muscle, how it looks like. So if you see, this is your infraspinatus muscle over here, which is completely fatty atrophied. So there is significant fatty atrophy along with edema. If you see two findings together, this is kind of a clue of subacute to chronic denervation which is happening. Why would there be denervation only in infraspinatus muscle? We need to figure out the cause because we have done an MRI. So we go down to our axial images and see the labrum. So once you start seeing the labrum, if you can identify, this is a small anterior superior triangle which we can see, but posterior superiorly you cannot identify any discrete labrum. Okay, this is definitely torn and doesn't look good. And then you see this fluid coming out from here and extending posteriorly into the spinoglenoid notch. So this is your paralabral cyst over here, which is extending into the spinoglenoid notch and likely impinging the suprascapular neurovascular bundle, and that is the cause of denervation which is happening in the infraspinatus. So again, labral tear, paralabral cyst, I trace it down, I still see labral tear over here, and then slowly the labral tear becomes, the posterior inferior quadrant labrum becomes normal. So this was your paralabral cyst, which is going into the spinoglenoid notch and causing denervation. So whenever you see muscle and nerve pathologies, you should together combine and think of some denervation happening. So just to sum up a little bit about denervation in the shoulder, the most common location is your suprascapular nerve. So suprascapular nerve comes into the suprascapular notch and it gives a branch to supraspinatus, and then it traverses further down and then it gives a branch to the infraspinatus, right, in the spinoglenoid notch. So if you have any pathology in the suprascapular notch area, then you will see denervation changes in supra and infraspinatus both. But if you have anything beyond suprascapular notch, that is maybe at the level of spinoglenoid notch or in between as well, then you will see abnormality only limited to the infraspinatus muscle. I hope I am clear. So your suprascapular nerve gives one branch to the supraspinatus in the suprascapular notch, and as it comes down into the spinoglenoid notch, it gives a branch to the infraspinatus. So if there is pathology at suprascapular notch level, then you see denervation in both the muscles. However, if the pathology is only at the spinoglenoid notch level, you see abnormality only in the infraspinatus muscle. So just to sum up this case, you should always look bidirectionally. So if you find a pathology in the muscle, go back and look at the any compression of the neurovascular bundle and vice versa. So overall, to sum up our labral section, what we always look at the labrum, try and identify variants and differentiate them from tear. So you should not call something as variant, some variant as a tear, because you do not want an unnecessary intervention. Look at the clues like we discussed for labral tear, and look for paralabral cyst whenever you look for denervation edema, because that would be the cause which would be going and compressing the nerve. Now let's move on to the next section, which is acromioclavicular joint. So first thing, let's just have a quick look at the anatomy. So if you see, this is your clavicle and this is acromion, which together form the acromioclavicular joint, which is lined by superior and inferior capsule, the thickening of which is itself called as superior and inferior acromioclavicular ligaments. Then there is articular cartilage, which lines the joint. So this is your capsule and articular cartilage. Then another important thing which helps the joint in remaining stable is your coracoclavicular ligaments. So this is your coracoid process and this is your clavicle. And there is a ligament which extends between the two, that is your coracoclavicular ligament. It has two components, one is conoid and the other one is trapezoid, right? So the conoid one is the one which is medial and trapezoid one is which is lateral. And as you would understand, the name comes from the shape. So it is trapezoid shape, it is triangular, and this is squarish or trapezium shape. So that is how the names come in. And you can have these developmental variants, which I'm going to come on in a bit. So, so this is your acromion and this is your clavicle. And if you see this black thing over here and here, these are your capsule or acromioclavicular ligaments. And there is articular cartilage, if you scroll through, which you'll see would be lining the joint capsule. So this is your normal acromioclavicular ligament, joint, how it looks like. Then moving to coracoclavicular ligament. So if you see over here, this is your coracoid process, and this is how you know that you are in the anterior sections. So coracoid process is anterior and you are in the anterior sections. And you see this ligament going in from here. And there is another ligament which is, so this is like this. And there is another ligament which is like this connecting over here. So just going back and forth. So this ligament and this ligament. Just keep an eye on this. So these and these, this is your conoid because this has apex towards here and this has a broad base going up. This is your trapezoid. So this is your trapezoid coming here and this is your conoid coming here. So these are the two ligaments, conoid and trapezoid ligaments, which you can see well on the MRI. Now let's see quickly some pathologies around the acromioclavicular joint. So first thing, if it's a young patient, what you need to be aware of is an os acromial. So nothing much, but your acromion is formed from four centers, that is your pre, meta, meso and basiacromion. So usually these fuse by the age of 21 to 25 years. What happens in fusion? Sometimes at this level where the blue line is, the fusion doesn't happen, and what you have in as a result over here is your os acromial. So if there is no fusion across this line which is happening, the thing which is left over here is called as os acromial. If you find it in a patient younger than 21 or 21 to 25 years of age, then you should not call it os acromial. But if the patient is elder than that, then you call something as os acromial. It is very often missed on other planes. So your axial images are the best to pick it up. As you can see over here, this is your os acromial over here. Why is it important? Just it's almost like a normal variant, I believe, but it's important if somebody has some localized pain or some stress over there, then you may see some edema along this along this arthrosis, or because of stress, you may see some edema in the os acromial. So if you see some edema, like in this case, there was edema across the arthrosis. So in such a case, you across this joint, so you in such a case, you are worried that this patient is having some stress injury or overloading injury. Otherwise, it's a more likely a normal variant. But if you pick this up, you need to mention that's more of like for a radiologist. Then moving on to the second bit, that is impingement. Now it's like a thing. So this Bigliani's classification has come up, which has given it as type 1, 2, and 3. There is another classification which gives a type 4 also, in which the type 4 acromion is just reverse like this. And it is said that type 3 and type 4 are the ones which can cause more of impingement. So this is anterior hook, which can cause impingement, and this is your downward beaking, which can cause again impingement. But this is something which is a dynamic thing, and impingement is a diagnosis, clinical diagnosis, which you guys need to make out. It's not something which we can make out on MRI. So personally, in our practice, we don't go over and label the acromions. If we see some big osteophyte or something because of degeneration coming up, we definitely go ahead and mention this. But we don't go into the classification, but it's definitely a call which you guys also need to take, whether you. So whatever I have read, it's like a dilemma kind of a thing, and few papers even quote that this is not something, and even my clinicians don't go nuts over knowing about the type of acromion process. But definitely, if somebody needs to know about it, we mention it in our reports. So you just need to know that these are the various types of acromion, and this type 3 and type 4, according to classification, is more probable to cause impingement. Although we cannot label something as impingement on MRI because it's a dynamic process, but on shoulder ultrasound, we can definitely label something as impingement. Then moving on to the third bit, that is chronic acromioclavicular joint loading. So it is most commonly seen with weightlifters because the acromioclavicular joint is loaded a bit. So you can see a spectrum of findings. What can be the spectrum of findings? You can have little micro instability. You may have stress, which may ultimately lead to osteolysis or early osteoarthritis. So this is kind of a spectrum which follows step by step if the loading pattern is not changed. So initially you may just start with this capsular thickening and edema, which may lead to this. So let's see all these things on MRI. Like I showed you a normal MRI. In this case, you can see edema around the capsule with some fluid within the joint. So this is an example of capsular thickening with edema, which is an early indicator of chronic joint loading. This may further be followed up by the next stage, in which you can see over here, there is marrow edema in the distal clavicle. And if you see carefully, you see this subtle fracture line over here. Sorry. So if you see this subtle fracture line over here, so this is a distal clavicular stress fracture. It's more common in the distal clavicle only. Then later, if not stopped at that level as well, it may lead to degenerative changes. So these are subchondral cystic changes with marrow edema, with some fluid in the joint and with little widening. So you're landing up and going into the early osteoarthritis phase. So this is kind of a spectrum which you need to know about. And then even you can have osteolysis of the distal clavicle, and there's a big gap which has been formed, which is filled with fluid. So this can again go into the same spectrum of chronic acromioclavicular joint loading. But if you see osteolysis, just keep these differentials in your mind and rule these out if you don't think it's a chronic acromioclavicular joint loading. So it can be because of other conditions like rheumatoid arthritis, because of some infection, which we might be able to give you a clue on, but sometimes it is difficult on radiology to differentiate those, and you need the clinical parameters to figure those out. So you need to just rule out the other possibilities if you see osteolysis and you clinically do not suspect chronic acromioclavicular joint loading. Then moving on to the last bit in the acromioclavicular joint, which is trauma. So there are 6 grades. It is important to differentiate grade 3 from 4, where the management changes. And as you all would be aware, so it goes from conservative to surgical if we go from grade 3 to grade 4. So radiology, from grade 4 onwards, you will be able to pick it up even on radiographs and clinically. So from grade 4 onwards, you do not usually need an MRI, but you need an MRI to differentiate grade 1, 2 versus 3. And I'm sorry, so management changes in these grading. So you may avoid any intervention in grade 1 and grade 2. So MRI plays a role, and I think 3rd grade is pretty controversial. So it would vary from orthopedician to orthopedician. So let's just quickly go through grades. So what is grade 1? In grade 1, there is just capsular stretch. So ideally, if you do a normal radiograph, you'll not be able to pick it. You need a load-bearing radiograph, and then you will be able to pick it up. And on MRI, you would see capsular thickening and edema. Then in grade 2, there is capsular disruption. So even without load-bearing radiograph, you will be able to pick this up. But on MRI, you would see, along with capsular disruption, you might see joint widening, and coracoclavicular ligament is just sprained, if at all. It is not torn. And if it gets torn, then you are moving towards grade 3. So the difference is, in this, there is only capsular edema. In this, there would be joint widening with or without some coracoclavicular low grade kind of an injury. But if you have coracoclavicular ligament disruption, then you move down to something what is grade 3. Grade 4, 5, and 6, just to sum up the topic, grade 4 is when you have posterior displacement. Grade 5, when you have in addition muscle injuries, and grade 6 is inferior subluxation with fractures and multiple injuries, brachial plexus fractures, ribs, and everything. So let's see a few examples. So this is a load-bearing radiograph which was obtained, and here you can see your acromioclavicular joint is normal. And because of load bearings, you can see that there is subluxation or dislocation of the acromioclavicular joint. This is a radiograph without weight bearing, and because it was pretty obvious, so you could see the acromioclavicular injury over here. Now moving on to the MRI, how you appreciate on the MRI. So what you need to do is, so this patient, so you can just ask me one simple question once I'm showing you this. So the question would be, how can you not see that this is chronic acromioclavicular joint loading? Because this same kind of a picture I showed you for chronic acromioclavicular joint loading initial stages. So to be true, as a radiologist, I cannot only on MRI tell you whether this is acute or this is chronic if it's only grade 1. It's your history, it's clinical history. If there is an acute injury or if it's a chronic injury, that helps me figure and put it in some bucket. So clinical history is very important if you want to differentiate acute versus chronic in very early stages. So in this case, as you can see, there is this capsular edema, superior as well as inferior, and there is pericapsular edema as well. So this is fine. And in this case, your coracoclavicular ligament is perfectly fine. It's seen through and through both the components. So this is just a case of grade 1 injury. Then moving on to grade 2 injury, you can see there is disruption of the capsule. The capsule is not seen at all. The joint has got widened with fluid within. So this is definitely kind of a acromioclavicular dissociation has happened. There is fluid, there is capsular injury. And if you see the coracoclavicular ligament, can you see this, how thickened it is? I'll just go back to the previous image. So this is how the normal two components look like. And you can see here how thickened. So from coracoid to clavicle and how thickened they are. But still they are continuous. There is no disruption. So this is coracoclavicular ligament sprain or a low-grade injury with disruption of the acromioclavicular capsule. So this is at least a grade 2 injury as we discussed before. And then moving on to this again, you cannot see the capsule, you see a lot of edema. So there is definitely acromioclavicular capsular injury. And if you try and appreciate the coracoclavicular ligament, there is a discrete defect over here. So this is one bit, this is the other bit, and you do not see anything over here. So just moving back and forth so that you can see. So this is proximal bit, this is distal bit, and this is your fluid cleft, which is over here. So this is a discrete defect in the mid substance of the coracoclavicular ligament. So this is something which is a grade 3 injury. So MRI really helps you to figure out and put injuries into a proper bucket. Now, actually, this case is open for you all to see and appreciate what do you think about it. And it has an important message also to pass on. But I'll just go through the case. So again, I see lot of edema in the region of coraco. So this is coracoid and this is clavicle. And I see lot of edema in the region of coracoclavicular ligament. Then I see the same area on my sagittal. So I see the ligament actually over here, but there is definitely edema and there is some hypointensity over here. And now if you look at your acromioclavicular joint, it looks perfectly normal. So ideally, this patient came to us with a history of injury. He was trying to lift some bed and suddenly the pain started. So it looked like an acromioclavicular joint injury. But actually, the acromioclavicular joint looks normal over here. But is there a coracoclavicular ligament injury? No. So coracoclavicular isolated ligament injury is very uncommon with the acromioclavicular joint being perfectly normal. So this hypointense thing which you are seeing over here and over here is your calcification, and this is nothing but calcific periarthritis. So this is something which can mimic and should be kept in mind clinically as well as radiologically, and a mimicker in quite a few locations. So just to sum up our acromioclavicular joint spectrum, you have developmental abnormalities like ossacromia, like we discussed. Don't label it before 21 years of age at least. Then impingement can be because of types of acromion, or it can be because of osteophytes. And impingement, it's not an MRI diagnosis, it's a clinical diagnosis. Then chronic acromioclavicular joint loading, you can see the spectrum ranging from instability to stress to osteolysis or early OA. And whenever you have a case of trauma, look at the acromioclavicular joint and coracoclavicular ligaments together. Do not mistake coracoclavicular ligament calcifications around. That is pretty known now. Then moving on to the next thing which we are going to cover today is adhesive capsulitis. I'm not sure if this was covered before, but I think this was covered before, but concisely. So we'll just go through quickly a few cases. So all of you know this is something which is known as frozen shoulder. Women and diabetic patients are most commonly affected. And usually the patient presents with a slowly progressive pain and more of eventually has more of restriction of movement. So how do you see whenever you get that history? How do you approach an MRI? Your careful concern is to look at the rotator interval and your inferior glenohumeral ligament. So we are in the region of rotator interval. Just to quickly sum up the anatomy, this is your subscapularis tendon. This is your supraspinatus tendon, infraspinatus tendon, and teres minor tendon. And this is your rotator interval, right? It has zoomed up image. It has two ligaments. One is coracohumeral ligament in the roof, and your superior glenohumeral ligament, this black band in the floor. And this is your biceps tendon, which is, so the ligament is going like this, which is a content, and there is a lot of fatty area over here, which is normally seen in the rotator interval. So this is your normal rotator interval anatomy. Then your inferior capsule. So this is the area where you need to look at on your coronal weighted images. So this is your inferior capsule, this black band, or inferior glenohumeral ligament. So ligaments are just nothing but thickenings of capsule. So this is your inferior glenohumeral ligament, and you can see how it normally looks like. Now let's see cases. So this is a case. Here you see, if you compare it with this image, how thin the inferior capsule was. In this, the capsule looks a little thickened, definitely a little thickened with some edema around it. And then you go ahead and see the rotator interval. So you see there is thickening in the rotator interval. So this sums up as the case of adhesive capsulitis. Now you can even call something adhesive capsulitis as early, mid, or late. So let's quickly have a glance at the cases here. So here you see there is this thickened inferior glenohumeral ligament with lot of edema really, right? And here you see that there is rotator interval, coracohumeral ligament and superior glenohumeral ligament thickening with edema in the same corresponding area. So you have edema in the areas along with some thickening. So this is kind of an early stage. As you move on to mid stage, the thickening progresses and edema remains a little mild. So more of thickening and less of edema. Similarly, over here, there is quite a bit of scarring. So all the fat has been replaced by almost the scar tissue. and you still have some edema. So this is kind of a mid-adhesive capsulitis stage. And as you move on, you just see a lot of thickening of the inferior capsule, no real edema. And similarly, you see scarring of the rotator interval with no real edema. So this is a case of late adhesive capsulitis. Just to touch upon, similar to adhesive capsulitis, similar kind of a history may be seen with some of these conditions. So this is a case of supraspinatus footprint tear. So you can see this footprint tear is extending from the articular surface with few intact bursal side fibers, and here it's seen again. So this patient might have a similar kind of a history. So this is has a fancy name as well, which is called as the pasta lesion. So articular sided supraspinatus tendon avulsion. Then you can have a similar history. So usually your calcific patients would present with a severe pain in that specific region, but sometimes there might be a progressive pain which is seen, and you can see in this case over here, this is a small calcification with a lot of subacromial bursal edema, and similarly that calcification is seen over here. So this is a case of calcific tendinosis. And lastly, this is your case of GT fracture, that is your greater tuberosity fracture. So there is a lot of marrow edema. And once you go down over here, and you can see this hypointense line over here. So this is your GT fracture or your greater tuberosity fracture. So overall, if we see how MRI is helping, so you can diagnose adhesive capsulitis. You have to look at these key areas which we discussed, and you can also pick up the other differentials which you would have clinically in mind, like calcific GT fracture, as we discussed. Now, lastly, touching upon the infective and inflammatory pathologies. So, first of all, before beginning this, it might be in quite a few situations, it might be difficult to differentiate something as a chronic infective versus inflammatory pathology. And in such cases, clinical input, inflammatory markers are really helpful. So how long standing is the history, how are the clinical markers, and those all play a role. This is a classic case of infection. So how do I see that? You see, so let's see this case first. So this is your humeral head, and you see a lot of marrow edema over here. And on this, you have a lot of marrow edema over here in the glenoid as well. You can see erosions happening over there. And from the erosion, there is this collection which is coming up. So whenever you see some associated collection, then you're pretty sure that you're dealing with something which is infection. So why is not this inferior labral recess? Why? Because this is being pushed over here. And obviously, you will be able to see it on consecutive image as well. So this was a collection which was communicating from the erosion. So here you see there is chondral loss, there is a lot of marrow edema, there is a lot of periarticular edema in the muscles. And if you look at the axials carefully, there is this thickening of the synovium. There is this synovial thickening over here. There is this synovial thickening over here extending all into the fluid. So you need to see synovial thickening. You may see again in both, but this much marrow edema with erosions with a collection is a clear pointer towards infective arthritis or a septic arthritis. So this is a case of lunohumeral septic arthritis. Now this is another case which is a little difficult case without history. So let's see this. I see this subtle marrow edema over here. Glenoid and rest of the bones look fine. There is definitely joint effusion, which is predominantly, I can see this in the inferior recess on this image. Then I move down over here. Again, I see joint effusion over here and here. And here I see some synovial flakes, and here I see some synovial thickening. So anything within the joint effusion which is a little brighter, or you as compared to the effusion, if you're seeing, which is a little darker as compared to the effusion. So if you see here, this is not a clear fluid. There is something which is lying within the fluid. So this is synovial thickening which is lying within the fluid. And over here also, if you see that there is some synovial thickening which is extending within the biceps tendon sheath as well. Similarly, if I see it on PD, this is not the fluid intensity. There is something within over here. And similarly, you can see that on sagittal weighted images as well. But this patient was a case of known some inflammatory disorder, and they were suspecting inflammatory etiology. So, if I would not have clinical input, I am not sure if this is not chronic tuberculosis as well. So inflammatory from tubercular and chronic infective might be difficult. The good pointers which you can see which would support your diagnosis would be if there is significant marrow edema, you are more likely thinking in terms of something which is infective. If you have an associated collection, you know that you're thinking in terms of infective. Then if you have synovial thickening, which is usually thin, little shaggy, but thin, very well marginated, that is usually with infective, but that is again really difficult to pick up. And the erosions are also a little more peripheral, but again, that's always not the rule. So the common things which usually help you in practice is your clinical history, your inflammatory markers, clinical suspicion. If you see disproportionate marrow edema, you see a lot of marrow edema like in this case, then you're pretty sure. Or if you get to see some collection, then you're pretty sure that you're dealing with something which is infection. Then this is another case in which you can see this subacromial bursal fluid. Excuse me. So again, in this case, you can see that there is this subacromial bursal fluid, and within the fluid, you can see this thin bodies within the fluid over here, all over the place. So these are, if you see, these are very thin linear bodies within it. You can draw lines across them. So this is something which is rice body. So this is something which on imaging we knew that we are dealing with something which is inflammatory, and then we figured out the history. Patient had a history of patient was rheumatoid positive. So we are dealing with something which is rheumatoid arthritis with inflammatory subacromial bursitis in this case. I think with this, I sum up the thing. We have an Insta handle in which we post cases weekly, and that is something which I like about. So if you want, you can follow us on our Insta handle and get updated with new cases every week. With this, I would just sum up things. If there are any questions, I would be there to answer. If there is something more which you are interested in knowing about, then we can show that in cases in the next session, because that would be case based. So it will be really good if you could share some points which you are interested in. Okay, so somebody has asked me how to differentiate a sublabral recess from a slap tear. So as I had shown before, so I'll just go back to that slide and just show you that again. So I'll show you both how we are seeing. So this, if you try and see over here, so this is something you see a fluid cleft. Let's zoom it. So here, if you see, this is a clear fluid cleft which is deep to the labrum. The labrum triangle is seen very well. So this is something which is not involving the labrum at all. This is something which is deep to the labrum. So this is sublabral recess. But when you start to see the signal, like in this case, so if you see the signal, there is this signal which is not deep to the labrum, it is going within the labrum. So this is a case in which there is a superior labrum which is torn. And then you need to figure out where from here, where the signal is going in, and depending on that, you can classify which type you want to fit it into. So important point to understand over here is you need to see signal within the labrum and then trace it going from where it is going here. So like in this case, it was involving the superior labrum and then going into the anterior and posterior quadrants up to the equator. So maybe fitting into type 4. Although we don't label types, we prefer to describe the findings and then go about that. Okay, so somebody wants to know about scapulothoracic joint. So what commonly we encounter about scapulothoracic joint, most common reason why we do an MRI is scapulothoracic bursitis. What we'll do, we'll keep a case of scapulothoracic bursitis for you next time as well in the set of cases. There's no point to show it on this because it doesn't even have a case. So I'll make a note of it. I'll particularly keep a scapulothoracic area. Anything else? So even you can post your queries, whatever are there. So I've got another question over here. Okay. Sure. So I have two more questions. So first one is, can you pick up Kim's lesion on, okay, that would have made it difficult for me, on MRI. So yes, so it might be difficult with nowadays with a high resolution MRI, which we are particularly doing, it is not difficult. So basically you need to pick a tear between the posterior labrum and so there is kind of not a complete detachment. But if you see altered signal which is extending between the posterior labrum and articular cartilage, then you raise a suspicion of that. So we particularly don't go ahead and call something as Kim's lesion, but yeah, definitely. If you see a subtle tear as well in the posterior superior quadrant, but I would also like to point out this time that posterior superior labrum is a very area where you see quite often the labrum looks a little heterogeneous. So it looks a little frayed in quite a few patients. So you need to be very particular. So if there is a suspicion where I see even a subtle signal in that posterior labrum, I always advise clinical correlation for localized labral signs or labral tests is recommended because we see it very often and we don't know how often it would be really symptomatic. Then there is another question on type 2 AC joint injury. So yes, very good question, I would say. So you want to know that type 2 AC joint injury look like a collection. So can we see it in tuberculosis? So as I told you, history is very important. If you don't have any history of trauma, then you are not dealing with something which is traumatic. Then you need to think more in terms of something which are the other pathologies, infective, inflammatory. Again, the entire spectrum comes in. So your history, when you are dealing with, until unless you think that is an AC joint trauma, you should not go down that path. But radiologically, if I come to, so you would see in AC joint tuberculosis, how would you see tuberculosis? First of all, is a chronic infection. But you would see marrow edema in the distal acromion and clavicle. You would see joint effusion. You would see pericapsular edema. And in addition, if you go down, you can see some lymph nodes. But usually the history for the two are really different and it should not, we as radiologists, if you ask us this question, it might not be possible to answer this without having a better clinical history with us. And in addition, if you're thinking of AC joint injury like type 2 and forward, you would also see something within the coracoclavicular ligament. So sometimes that might even be a clue to your thing, whether you're dealing with something or not. But history is important, that we tell radiologists. So please do make your notes with all the good history in it so that that helps us as well to make better reports. I think that sums up things and the questions. Thank you, everyone. I hope the session was helpful. You can just post one I have got, that is scapulothoracic region. Something else if you want about, then do let us know. Bye. Good night. Take care.